She said
There's 2 times tomorrow. Let's see.
1 to 4 and
It's like 5 to 7.
What's tomorrow?
And then 1 to 3.
Is tomorrow exactly the same as tonight? And
I've changed it, so you know. Yeah, 1 to 3 and 5 to 7.
Yeah, 1 to 3, 5 to 7
Yeah.
tomorrow. 1 to 3 and 5 to 7. Because that's what I have written down, but she said 2 to 4 and
Yeah.
something else. Okay. Well, I'll be around it. Okay.
Is it?
Okay, so you just got done with the test, so I'm sure there are many content you guys are gonna fly through. So, delegation, what can a nursing assistant do?
oh, I have a whole flashcard.
Vital signs,
Blood sugar,
ADLs,
Ambulating,
ambulating,
bathing,
Transport.
yep, transporting, so routine unchanging procedures, glucos scans, so basically, and what about LPNs?
They could do trachea, like,
Yep. Anything sterile,
reinforced
trachea, reinforced,
Yeah.
yep, they can give meds,
They
they
just
don't
can't
push
give
IVs,
IV meds.
yeah,
And they don't do blood.
correct.
Correct,
They
right?
can monitor the blood, correct?
They can,
They just monitor it once it starts, right?
They could do vitals.
They could go in and do vitals,
So you
yeah.
can't, they can't do the double check though.
No.
They're not gonna do the double check, they cannot do the double check, and they shouldn't really be there for the first 15 minutes when it's, that time for the reaction. Okay, so with delegation, it's always, in addition to priority, who you're gonna see first. Those typically your ABC type advances, look to see which one is the most unstable. And the other one is, who do you room with who? So, with thinking of your patient population, what type of precaution do we maintain for HIV?
Standard.
Standard, so they can go in with any type of patient. What about your neutropenia?
By themselves if you can.
But, yeah, so we want a private room for them, yeah, okay. And then, pretty much everyone else. How about your, manic, personality disorder?
Separate them before.
So we want, we don't have to necessarily put them alone, but put 2 manics together. Because we want, a less stimulating environment.
So no 2 manics together?
Not if they're in their manic mode, it's gonna be a really difficult situation. All right, so with leukemia and Hodgkin's, my biggest concern.
Bleeding infection.
Bleeding infection, very good. So with neutropenic precautions, that's, your
No fresh
low white
food.
blood cell. So first of all, what do we have to ask them to watch for? So they're at risk of infection, I'm gonna say you're gonna go home and watch for,
No gardening.
so
Fever.
fever, cough, congestion, sore throat, anything that has to do with a cold, I wanna know about it. So now as far as precautions, yes indeed, I do want, hand washing, what else?
No gardening. No fresh food.
Bottled water.
Bottled water,
No fresh
No crowd.
no emptying,
No
no
feces,
little
like
box,
connection.
no fresh flowers, fruits, very good. And neutropenia precaution has to do with bleeding. So again, they can have a complaint of bloody nose, gums bleeding. So what are some of the precautions we want for them?
Soft toothbrush.
Soft toothbrush.
Don't blow your.
Electric
No
razor.
blowing your nose.
So no blowing your nose, no straining, going to the bathroom, no contact sports, trying to minimize IM injections, gotta hold it for 5 to 10 minutes, definitely gonna hold it a lot longer after. No aspirin, no ibuprofen, no anticoagulants. Okay, for bone marrow transplant, what bones do we, for aspiration?
Sternum.
Sternum and the iliac crest. very good.
I remember that.
So, now for a bone marrow transplant, what are my concern? Infection, yep, they're at risk for infection. Okay, so someone has thrombocytopenia and I'm concerned they're losing a lot of blood. What's one of my first vital signs that's gonna change to tell me they could be hemorrhaging?
So low.
Blood pressure,
Low blood pressure, high heart rate.
Yeah, yep, so low blood pressure, increased heart rate. So really your heart rate jumps up first because it's low volume and it's trying to pump to keep everything going. So that's usually your first sign you're going to see. Okay, the cells for Hodgkin's. The Sternberg cell, very good. And let's see, I think I hit everything here. For renal, chronic renal failure, what would I expect? I pick up my lab results and what am I expecting?
High creatinine.
So high BUN, high creatinine. What else?
Urine output?
What is-
urine output?
High phosphorus.
Yep, the urine output is probably gonna be low.
High phosphorus.
High phosphorus,
High phosphorus, low calcium.
low calcium. So that's what I'm expecting. And then as soon as I have low calcium, high phosphorus, that imbalance puts them at risk for the pathological fractures. But then I have all the low calcium issues too. So the tetany, the spasms, the tingling sensation, the positive trousseau, the positive Schwarzstein. So all of those occur too. Tell me what are the signs and symptoms of peritonitis? What is it? Rigid abdomen is, so you can sometimes think of the key one, that guarding rigid abdomen, that's one of the key ones for peritonitis. Muscular rigidity, all those, just guarding, tenderness. So with renal, when is it an emergency that you're gonna call a physician regardless of what's going on?
What did you ask?
For renal, when am I gonna call a physician?
Under 30.
Under 30. Under 30 an hour. So just look, if it's less than 30, call the healthcare provider. And big thing, if they have to have external devices, you probably get into much about it, but the ilioconduit, really body image, anxiety, those type of things, and again, infection. So for hemodialysis, AV fistula, what are some of the things that we have to do every shift?
Kill for.
So we're gonna check for a bruit and a thrill, and what are my precautions?
You can't.
No BP on that arm, no constrictive clothing on that arm.
You can't lift one.
So the lifting, so they shouldn't be like holding things, pressure on it.
A bag or anything.
So what's that?
Like a bag, a purse.
Oh, I see what you're
Yeah.
saying, it's gonna cause
Bag.
constriction, yep, so a pocketbook that's gonna, put some constriction in, no, very good. All right, so peritoneal dialysis. So it goes into the abdomen 4 times a day. I dwell in 2,000 cc's and I put it down to drain 4 hours later. And I walk in the room and I only get 30 cc's out. What am I gonna do? I'm gonna
Move them
reposition.
around.
So I'm gonna first side to side reposition, trying to get more fluid out. Okay. And someone goes to hemodialysis and after dialysis they come back and complain of a headache and restlessness. What's going on? Disequilibrium syndrome. That's just a PERS from rapid shift of fluid. So what medication do I need to give? So let me continue further. So disequilibrium syndrome puts them at risk because of the cerebral, the rapid shift of fluid, cerebral edema, causing them risk to having a seizure and coma. I'm gonna always have on hand, PRN, the phenytoin or dilantin, it's the same med. So we're always gonna give that if they come up back and complain of headache, because we do not want a seizure. All right, so what type of diet am I putting someone on renal failure?
Low protein, right?
So what was it?
Low protein, right? Is it low protein?
Renal diet.
And so renal diet, it's
Probably
definitely
low sodium.
low sodium,
Low protein.
low potassium.
Because of the food.
Would you increase the calcium?
And then I could increase the calcium if the calcium's down. Yeah, okay,
So
good.
it was just low sodium, low potassium, high calcium.
And we may be on a fluid restriction,
Okay.
so, yep, could be on a fluid restriction. Definitely probably more on a fluid restriction with hemodialysis, maybe not so much with peritoneal dialysis. So sometimes it's a little bit more freedom.
You might increase.
So what type of things put people at increased risk of renal calculi?
Low.
Wait, can you repeat that again?
High calories. Oh, hyperparathyroidism?
Hyperparathyroidism will, yeah, which is high calcium, you were right. What did you say?
No,
How about dehydration?
Dehydration, isn't that?
Dehydration is the most
okay.
common, so we're gonna increase fluids. Okay, so let's see. So an AV fistula that's not working right, that may have some obstruction, some, just insufficiency, venous insufficiency, what would I, so if I had it here, what would I expect in my hand?
Plus blood flow.
There's an obstruction.
Less blood flow, so keep going. So if I,
Arthritis, cold.
it's gonna be cold, it's gonna be pale,
Do that,
Oxygen blue.
like the bypass,
they would have to probably do a bypass. But again, my hand's gonna be pale, it's gonna be cold, I'm gonna have numbness, tingling, a little bit of pain. Okay, good. All right, so questions on dehydration, leukemia, or renal? This is like you're getting now the top most important things that you need to know. All right, cardiac. Which section of the EKG will tell me they had MI ischemia or injury? ST segment. So ST segment is what's gonna be. So if, I don't see any marker, but, a hot spot. I go to do an EKG strip, what's that first one? P. T. So you definitely want to know your EKG strip. You are definitely going to have rhythms. So your common rhythms. I know I have passed out before some of the common rhythm strips. Normal sinus rhythm, everyone should know. Ventricular tachycardia, just looks up and down, up and down. Oh, is that for the board? You gotta make sure it's, dry erase marker, that's it. So, so VTAC, and then VFib is more the sawtooth. And then we have atrial flutter, where you have, and then you have your QRS. So you have normal, the ventricular is normal, it's, when you have an atrial flutter, it's the atrium in between that's really irregular. But with flutter, it's regular, so this one should be over a little bit more, where AFib, it's irregular. And then make sure I get this back to you. What about what I expect from a block? I think I heard possible block, at least that's what Dave told me.
It's like third degree.
Yeah, 3rd-degree block, so what are you gonna expect?
The non-connected, they're not connected to the
Yeah, so what happens is you may see no P waves, there's no relation in P waves, or you could see 2 P waves, and so it just looks weird. So, but know your most common arrhythmias. So, and the other thing is if I do have VFib, what am I doing first?
CPR.
Defib.
DFib, VFib, DFib.
Oh, I think I have something. And we
She
talked
said
about that
CPR.
last time. You said you're not gonna see it again?
You're not gonna see it together in the same question. I mean, it's not gonna have them both there.
The incident.
Yeah, well, that's, most common, you hear everyone say that, VFib, DFib.
It just rhymes. Let's go on that rhyme.
All
I
right.
think it's CPR.
So if someone has AFib, what's my concern? Clots, pulmonary embolism. So that's my concern. Somebody has a pulmonary embolism. What do I want to do?
Heparin, warfarin,
What is it?
heparin or warfarin.
Yeah, I'm gonna need blood thinners, but I'm gonna really manage the shortness of breath. So I'm gonna get oxygen if it's pulmonary embolism. So that's gonna be my biggest concern right away. All right. So, what med, will cause chronic cough? Lisinopril. What cardiac med do I need to keep away from asthmas? The beta blockers, yeah. What med is going to cause me low sodium and low potassium? A diuretic, but which one? The potassium sparing one, furosemide. So which one is going to cause low sodium and high potassium? Spirulactone, very good. Someone who has a cardiac cath post-procedure, my biggest concern, bleeding, neurovascular assessment, very good. All right, so those are probably the biggest things for cardiac. Yes.
What about like the heart valve issues?
I don't know, let me just see something, because I do thought no, I'm not sure that they're gonna get into any valves or anything.
So we don't have to like go over those for the final.
Review them, but pay more attention to what I'm saying. You absolutely want to review them. So, all right. Because again, endocarditis, what is my biggest priority? It's an infection, but it's still airway. So airway, breathe in, is still my biggest concern. All right, high pressure alarm, what's going on for a vent? Blockage, could be a mucus plug, could be biting, could be that it's kinked, they're breathing against it, coughing against it. What about low pressure? Disconnection, a leak, okay. So someone who's hypoxic, so hypoxemia, what's one of my first signs that are gonna change, vital signs that's gonna change?
Level of consciousness.
That's
Or the
gonna be a
O2.
late one,
Extra O2 stuff.
tachycardia. So again, but the vital sign that's gonna change first is my heart rate. And that should key me in for low oxygen.
Inside, right?
Yeah. So because the situation, I'm suctioning somebody and their heart rate starts to go up, what do I need to do? Stop and pre-oxygenate. or oxygenate or pre-oxygenate, whichever. All right, acute respiratory distress syndrome. Some of the things that I want to do for care. I want high flow oxygen or a vent. What else do I want to do?
You need
Flowers.
I want good mouth care,
sedation
sedation vacation,
EVT prevention?
yeah, I want to do DVT prevention.
He's kind of high valid, right? No, I'm just kidding.
Yeah, and it's reposition, side to side, prone helps to expand the lungs, don't forget the prone. And how are they, what about fluids? So probably mostly a fluid restriction, how are we feeding them?
TPN.
TPN or parental, but usually TPN, okay. So ABG pH less than 7.35, acidosis or alkalosis? Acidosis, yeah, okay. Pancuronium, why do we use it for vent?
Oh, I don't know what that is.
Paralyze them?
Yeah, so it's a neuromuscular blocking agent, induces paralysis, suppresses the client's respiratory effort. But again, it allows the vent to work.
It's a neural block.
A neuromuscular blocking agent.
So is that's the one you give, you gotta make sure they're in oxygen, they're being oxygenated.
Correct.
Okay.
What was the man name?
Pan is, I can't even say that.
The pancreonium.
Can't say that.
All right. So definitely want to refresh on ABGs, because ABGs in tell me what this rhythm is, should be an automatic. No ands, ifs, really, they should be 100. Head injury. We'll go to head injury for a little bit. So with head injury, the first initial symptoms of increase in cranial pressure.
Mental status.
Change in mental status, so change in level of consciousness, restlessness, irritability, confusion, all those have to do with level of consciousness. Then we may see an increase in systolic pressure, widening pulse pressure, and bradycardia. Again, that's the Cushing triad. Now, what is the normal ICP?
Under 15.
5 to
Wait, no,
15.
yeah.
So someone's running 23, it's up, so we know it's elevated. What can we do? Lift the head of the bed, yeah.
BBH.
That's for CPP.
And again, should the head be at 90 degrees or should it be 45?
30 to 40, somewhere in that area. Okay, Glasgow Coma scale. So measures level of consciousness, your eye open, best verbal response, best motor response. So they're at 13. Tell me what they can do.
Almost everything.
Pretty much everything. Yeah, so that's, 15, they can do everything. So you just want to make sure, you know that someone can move their extremities on command, and they're alert, and they're oriented. So some meningitis can be at risk for developing increased intracranial pressure. So again, we want to know all those symptoms, confusion, and all of that. But what other symptoms does someone have with meningitis? The neutral rigidity is the most common.
I was gonna say that rash sometimes.
Yep.
That you roll with the glass.
So now for seizures, we typically, and I had said earlier, for the dialysis patient to have the Phenatin, the Dilantin on hand. What are side effects? What are you taking if seizures or preventing one after that fluid shift in dialysis? What are some common symptoms of Phenatin, the Dilantin? I didn't hear that. So some of the most common symptoms are problems walking, slurred speech, tremors, rash, so we wanna monitor for skin rash. Good oral hygiene, because they have the gingival overgrowth. What's the normal phenytoin level? 10 to 20. Yeah, 10 to 20. All right. And questions on head injury. Because right now, you guys are throwing them out. A lot of this is gonna be a review. You just, 2 tests were not that far apart from each other. So a lot of this should be coming right back. All right, HIV is new. What are the initial symptoms for HIV? Flu-like symptoms, night sweats. And so, what lab work am I typically paying attention to that I'm concerned? The CD4 T cell count. So less than 200, it means AIDS, and it puts them at risk for all those opportunistic infections. They're also at risk at that point of having candidus of the mouth, a lot of yeast infections, anyone who has a low immune system. So if they reported painful purplish red rash, what am I thinking? Kaposi's sarcoma. What lab work do they initially have to diagnose HIV? The ELISA. If ELISA is positive, then we send them off to
Weber's blot.
Western blot. Very good. So, how is it transmitted, HIV? Body fluid, sexual intercourse, IV, yep. Childbirth, breastfeeding, yep. Okay. So I am taking care of a person with HIV, and you told me it's contact precaution, and I have to go in because they do have cystic pneumonia, and I get a suction. And there's a chance of me getting splashed. What PPE am I going in with? Personal protective equipment. Face shield, gown, and gloves. Yep. So again, it has nothing to do that they're HIV, because they're contact, they're a regular standard precaution, but anyone that I'm going into suction that potentially has splash, and that's what I'm gonna use. So anyone, including my HIV, I get a needle stick, what am I gonna do? What's my priority?
Wash it off.
Wash it and get help, report it immediately. All right, so what do we treat it with? Antiretrovirus medication, zidovudine, zidovudine.
That's for pregnant women, right?
So this is part of the antiretroviral therapy. So what's the biggest concern about that medication side effect?
For which med?
Which one?
The
Zidovudine.
zidovudine.
Oh.
What is it? Bone marrow suppression, very good. So myelosuppression, so anemia, white blood cell counts are down, thrombocytopenia, all of those are down. All right. And the other big thing that tends to be big for HIV happens to be wasting syndrome. So watching for losing weight and trying to get them to eat smaller meals and try and take care of so that they can gain weight. All right, neuromuscular is not going to be big. Somebody with a neuromuscular disorder, regardless what it is, muscle weakness, what does it put them at risk for? Falls. So safety is a big concern. Falls, skin breakdowns, they're at risk for you know, just weakness,
Pressure
fatigue,
ulcers.
and so spinal cord injury. Tell me what level would be considered a quadriplegic slash tetraplegic? C1 to C8, and what about a paraplegic?
T.
T1 down, okay. What level do I have autonomic dysreflexia?
T6 above.
T6 and above, and someone who has the autonomic reflexia response with T6 and above, and a check blood pressure, and it's high, what's the first thing I want to do? Sit them all the way up, and then I want to check for the
Check here.
cause. What are the three common causes?
Bladder.
Full bladder,
Pressure, skin pressure and full
skin
Clothing.
breakdown pressure, and
Bowel
full
infection.
full bowel constipation. Those would be mostly your three common. Okay. And this guy didn't even go over to spinal cord yet. I just kind of threw those
I had a
out.
patient that had that the other day.
Autonomic dysreflexia?
Yeah, I got the nurse because I didn't like pick up on it right away, and then when she was like checking the Foley, I realized what it was, and when we rolled her over, she got a menstrual cycle.
Ah, so you have the menstrual cramps.
As soon as we cleaned the blood off of her, she was literally fine. All the
Oh,
blood
wow.
pressure and the heart rate returned to normal like less than 5 minutes later.
All right, so spinal shock, what's my big sign and symptom? No reflexes below the level of injury, and then neurogenic shock.
Low, yeah, low BP, low heart rate.
Low, they're both low, both the heart rate and blood pressure are low. So someone with cervical injury, you know, I'm gonna be concerned, respiratory system, I'm gonna be concerned swallowing, I'm gonna be concerned with their blood pressure, because again, if it's, neurogenic shock, it's gonna be hypotensive, I'm gonna be concerned for their bladder, their bowel, their skin, so many different things that we're gonna be concerned of, initially with somebody with a spinal cord injury. All right, so, let's see. I want to get into ethics. So, fidelity. What is fidelity? It's a promise. Keeping one's promise, keeping your word. You said you were gonna come back and you didn't come back. You said you were gonna keep your appointment and you didn't keep your appointment. So it's like keeping your word or sticking by rules or vows, like marriage vows, rules of standards out there. So that's fidelity. Beneficence.
Say that, oh, Maleficent?
Not non-maleficence, beneficence.
It's doing good. right?
Yeah, it's doing good. So doing good for others. So, you know, just allowing somebody who's really upset and they're about to take someone to surgery, allowing them in the room before they come. You know, so again, it's just helping them. About autonomy.
Making their own choice.
Making their own choice, so they're able to make their own decision, what they want to do. Do they want to refuse treatment? Do they want to have something? And if somebody chose to be DNR and then the family comes in later and says, no, I don't want them to be DNR, who are we following?
The
The
patient.
patient.
The patient who requested DNR.
What is, okay, so I
I
have a
got a
question.
question
What-
about that,
Yeah,
this guy, and it was like, it said something about like explaining to the, like getting research to explain to the family about like backing up a person's decision, like it's their decision, who cares?
If someone has a DNR, would you require them to have a living will?
So most of the time, not always, but yes, especially if it's more of a long-term situation. You
Okay.
want, you want a portable DNR and you do want someone to make decisions if you can't. Sometimes everything's happening so
But
quick.
Your healthcare provider, your health proxy.
Your healthcare proxy,
They can't change your DNR thing, can, well, they
I
could
guess
if they want to.
yeah.
They could if they want to, but if you want it to be DNR, and then later on they're like, actually, no, I don't want them to be, like, what do you do?
Well, you want,
Get
so
rid
you
of
wanna
healthcare
pick the
proxy.
right healthcare proxy. It's gonna follow your wishes.
Some people just aren't ready to let go.
What about normalefficence? So this is to do no harm. So when I think of normalefficence, a lot of questions tend to stem from research. That we want you in this research study, it's not gonna harm you, may not benefit, it just doesn't harm you, so normalefficence. HIPAA, confidentiality and privacy. Veracity, to tell the truth. I make a bad error, I need to tell the truth. I want to let you know, I gave you 2 digs this morning
that
instead of
word
1.
Veracity.
And so informed consent, before a patient signs an informed consent, what is the steps before
The
informed
provider
consent?
needs to explain it.
But you need to witness the provider explaining it and.
So we got a witness, but even before witnessing the
They need to be
signature,
informed.
we need to be informed, the risks, the benefits, and even before that, nurses, we check, we
To make
assess
sure they
people's
understand.
readiness to learn. So why are they coming in if they can't even learn? So yeah, so we assess readiness, benefits, the risks, witness, then they're gonna sign the informed consent, witness it. Then typically, they're going to go off, they may at this point have some type of sedative to relax them. When do they do a timeout?
Right before the
Right before the procedure.
Right before the procedure, then they do a timeout. Everyone knows what timeout is?
Yes.
That they stop and they make sure it's the right person with the right procedure, the right leg, that it's, everyone stops and says, okay, this is Karen Manning, she's coming in for, an appendectomy. And oh, I thought we were doing a leg amputation. So they wanna, it's the timeout, everybody has to stop, we gotta make sure the informed consent's in the shot and that everyone knows what they're there for. Okay. All right, so that is, so talk to me what evidence-based practice is.
It's like, practice off of research, like about the mouth care with pneumonia.
Yeah.
Like they said,
So,
doing
yep,
mouth
so
care
it helps, to advance the science of nursing, so we're doing, care backed by evidence, backed by research. So what is the PCOT? Is it called the PICOT?
It's like the person, yeah.
Person or patient.
Person,
Problem.
yep. The person or the problem, what's the I?
Intervention.
Intervention. C, comparison,
Outcome.
then outcome in time. Yep, okay. All right, so now, endocrine, hypothyroidism. Slow metabolic rate. So give me some symptoms.
Constipation.
Constipation, overweight, weight gain,
Hyper.
cold, so they're mental,
Hyper.
sluggish, and everything's just slow, so
Brittle nails and hair.
brittle hair,
Hyperlipidemia, the high lipids.
the high lipids, hyperlipidemia.
Yeah, that.
Now, what am I treating this with? Levothyroxine. How do I know levothyroxine's effective?
Because if they don't have the symptoms of hyper and all the symptoms of hypo,
All right, I have neither. How do I know it's effective?
check the level.
No,
What?
the calcium level.
TSH is going to,
It's gonna be low.
it's gonna come back down. So if I'm hypo, the TSH is gonna be up. How do I know it's effective? It's coming back down. But you are right, because if I give too much, and I have symptoms of hyper, and too little, but if I don't have either, how do I know it's working? So check the level. All right, hyperthyroidism. Symptoms.
They have diabetes.
Diarrhea, giddiness, nervousness,
Skinny,
and a heat
Weight loss.
intolerance,
weight loss.
weight loss. So,
The exothel, what is that, the hyper?
that was gonna be the key characteristic of Graves' disease.
For the eye.
Yeah, the exo, I don't know how to say it.
Ectothalamus, that's the bulging of the eyes. And, what's my concern when someone's hyperthyroidism? Thyroid storm. So high blood pressure, high fever, again, everything's in an exaggerated, state. So, some,
Mixed edema with hypo.
yes, yeah, and that's all my cardiac issue. So, someone who had a parathyroidectomy, what am I concerned with? My calcium
Is
down and phosphorus is up.
with hypo.
So, and we're gonna keep on hand calcium gluconate. So, and now if I have hyperparathyroidism, calcium's up, phosphorus down. Okay.
How do you, what's the net to bring that down again?
For hyper, it's the PTU, the tapazole. All right, emergency room. So, drug overdose.
Narcan.
Narcan, what's my biggest symptoms? I'm respiratory, cardiovascular that I'm constantly assessing. Heat stroke, no sweat. So tachycardia, no sweat. And again, it's gonna be a big concern, if someone's breathing fast, heart rate's fast, and they're not sweating, it could cause them to die, they could die. And so someone comes in, ski accident, motor vehicle accident, and they've done the priorities of airway breathing out in the field. They come in, the person is looking at you. What's the next step? I did A, B, it's C. It's now, I'm gonna look to see, how am I gonna know someone is hemorrhaging?
Vital.
Vital signs.
Vital signs.
Yep, up with a pulse, down with the blood pressure. Someone, personality disorder, depression comes into the emergency room, my big concern? Suicide. And what do we, when we suspect suicide issues, what are we gonna do?
Safety watch, 101.
Well, one-on-one, but I wanna ask them, kind of right out and ask, if they're gonna hurt themselves and do they have a plan? Someone who's been sexually assaulted in the emergency room as a nurse.
You don't leave them alone.
So we don't leave them alone, so now we wanna certainly, provide privacy, sensitivity, and get one of the, expert sane nurses to come in. Somebody who drinks something like antifreeze,
No.
milk or water to, dilute it. Okay. Bioterrorism, chemical spill, what position? Standing up. Radiation leak.
off
Where are we
everything.
gonna set up the triage? Outside, and we wanna decontaminate. And how are we gonna decontaminate? We're gonna take off the clothes, and we're gonna do
Wash.
soap and water scrub. Now, you are the nurse, and you hear that there is a factory explosion. You have no idea if there were chemicals or not involved. So what safety equipment do you use? The highest going, so which would be a respirator. So the highest safety equipment, so if we don't know, the highest level of protection we can get. So question? Okay. Somebody who is having respiratory pauses with the respiratory and from an
They're black.
explosion,
They're black.
and we reposition their head.
2 times the black.
Yep, we're gonna tag them black, and again, someone with 60-70% body burns, they're gonna be tagged black. And for anthrax, what medication do we want on hand?
Penicillin.
Penicillin. Okay, that's your basic bioterrorism,
Having someone
liver, the hepatic encephalopathy, what's going on? Too much ammonia? How do I get rid of the ammonia? Lactulose. So lactulose, how many stools am I looking for a day?
2 to 3.
Yes, we're looking for somewhere from 2 to 3 soft stools a day. We don't want diarrhea. And what are some of the physical signs I may see with someone with hepatic encephalopathy? The flapping, the hysterex, and then their poor handwriting or trouble walking. And with esophageal varices, if they have a bleed, what do I want to do? What's my medication? Octreotide is a better choice. And I may use one of those Blakemore tubes, and I'm going to blow it up and it's for pressure. What are my precautions once it's down there?
Respiratory.
I got to stay in the room and have scissors on board and monitor for any respiratory distress if it does ride up. So for other symptoms with liver failure, jaundice, what else? Ascites. What is it? Edema. So edema, ascites, and again, your hepatic encephalopathy and esophageal varices. Got a question?
What was the med called? That's
The octreotide. All right. So let's see. All right, we did that. That's all the ethics, the spinal cord, the endocrine. All right, so here's the thing. We have hit everything except your personality disorders.
Which we need to hit.
Which we need to hit. But here's the thing. I'm probably not the best person to do personality disorders. So what I was looking, right before I came up and I started, and I'm gonna throw out some things to you, is I was trying to look to do it in an easy way, because everything I kept pulling up had 20 plus pages and it was just driving me crazy. So I'm trying to narrow it down really small. So, you know, yes, you have those clusters, A, B, and C, but if I just leave borderline personality, so borderline personality, what type of things do you think of for someone borderline personality? Splitting? Absolutely. So they tend to try and split stack one against the other because they tend to be manipulative, dramatic behavior. So we've got to be very careful about that. So as a nurse, you need to stay neutral, consistent approach with all nurses with this patient. And just because they're so manipulative, typically nurses need to trade off with each other so they don't burn out. And we don't want them splitting. So it's not uncommon for them to say, you know, oh, I'm so glad you're on tonight. You're the only nurse that pays attention to me, the only nurse that does this. So an appropriate response would say, you know, we work as a team and we can all provide the same care. So we don't want to feed in and allow the splitting to happen. So obviously any of the personalities, again, if they, especially if self-mutilating, do they, you know, get suicide ideations, and do they have a plan? So I'm going to try and really summarize those, but I want to go into the meds. So the meds are going to be on the test. They're going to be on the NCLEX Haldol. what is some of these adverse reactions to Haldol?
Yellow line, green halo.
No, that's,
No,
That's
that's
ditch.
the
Oh, okay.
Okay, but
that's the one we just talked about too, like.
the hill rolling.
so
Kinda
one
like
you are, just heard that you're gonna have EKG changes, prolonged QT intervals, and they're at risk for cardiac arrest, torsade, what is it called?
Torsade twist.
Torsades twist. So they're at risk with Haldol. But the other thing they're at risk for is the extrapyramidal symptoms. So again, when you see Parkinson's, you have idiopathic Parkinson's, but you have Parkinson's syndrome as a result of antipsychotic medication, and this is one. So the extrapyramidal symptoms include movement disorders and associated again with the antipsychotics. So the tremors, the bradykinesia, all those would stop if they stop the medication. But again, Haldol, also the cardiac dysrhythmias. So, other thing you really need to know about neuroleptic malignant syndrome. Again, anything that's life-threatening tends to go into the test. So, yes indeed, neuroleptic malignant syndrome, rare but potentially fatal adverse effect of antipsychotic medication. It changes level of consciousness, seizure, muscle rigidity, fever, and stupor. So again, we've got to be very careful if they all of a sudden have changes in consciousness. Thorazine, which the other name, chlorpromazine. I just want to make sure you guys are getting the right. What's my chlorpromazine? That's Thorazine. Big side effect, tardive dyskinesia. So tardive dyskinesia, protruding and twisting movement of the tongue, puckering, smacking movement of the lips, bulging of the cheek, chewing movements. So that a lot of movement with the tardive dyskinesia. So this is the big.
And this is not irreversible?
Yeah. Okay, and then we said Haldol, you have the EKG changes, and you have the extrapyramidal symptoms. All right, and again, for this, it could cause death because of the torsades. All right, so what medication am I missing? The other big medication, the clozapine. This one is, we need to do blood work because this has the agranulocytosis. Cytosis. All right, so those are the big medications. All right, so now you have someone who's on your unit, or maybe you're on a psych unit, and you have someone who may be manic going around in their manic state, running through the unit, knocking things over and pushing people. What are you going to do?
Try to get them out of the distraction.
What is it?
You want to distract them by getting to do something else?
So,
Get them away from that patient.
actually, at this point, we're going to do seclusion and possibly restraints.
That's what
So we have to get the unit in control. So yeah, there's nothing else we're gonna be able to do. A lot of things with psych, it's difficult because it's like, how do you respond? I mean, most of them, you want a consistent, firm approach. We never want to argue. I mean, to argue with someone whose personality disorder doesn't make any sense. Again, it's consistent, firm, and everyone should be doing the same thing. With schizophrenia, if they have hallucinations, we do want to directly ask them what is the hallucination. Why? Because it could be a safety issue that they're hearing voices tell them to wake up in the middle of the night and kill everyone on the unit. So we really want to know what it is. I don't want to feed into it and say, oh yeah, no, I see the pink elephant there too. We don't want to feed into it, but we want to directly ask them what's going on for safety.
Is that the only time you really ask them what's going on, is when you're in that manic phase?
Well, manic or schizophrenia doesn't necessarily have manic, but they certainly, we're gonna ask them what's going on. Did anyone come last night to Catherine Harris? Anything that you can share with the group that she said? 'Cause I got the meds. One of the things I want someone's going for an electroconvulsive therapy, and they said, oh my God, I don't wanna go, it's gonna be so painful. What's your response?
Like you'll be under.
Yeah, it's not painful because you'll be sedated, you won't feel anything. So let's see what else I have here. So again, I was going back to mania earlier. I'm just gonna have you look over your notes and you can tell us. But again, 2 manic patients in the same room, especially if they're both in their high manic stage, doesn't work well, because there we want basic, simple furniture, bed, and that's about it. You know, you're not looking for a lot, and you're trying to calm them down. So go ahead.
The only thing that she said was like to validate the feelings, so like feelings of the hallucinations.
Yep.
And she said 50% of schizophrenia and bipolar have drug and alcohol problems also.
Yep.
And that's kind of the only thing you did. Well, she did mention about the how though, is, so the adverse reaction is this dystonic reaction, like that, the jaw stuff. So she said to prevent that, you would give, I spelled this med terribly wrong, I don't even know what it says. Conjantine or Artane or something like that. And you would give Benadryl for the reaction.
I think it's Artane that we give.
Artane, yeah, that's what I have.
So yeah, because I got a lot of notes that I took, like, you know, someone's upset and angry, borderline personality, you know, discuss clients' feelings and setting limits. You know, again, you want to focus on the feeling, but be firm and consistent at the same time. So, and then borderline personality, they have to be 18 years of age. It can't be a result of, it's more than just alcohol and drugs. So there's behavior issues, it's more than just alcohol and drugs. Let's see.
There was one other side effect of how, for the neuroleptic malignant syndrome that she mentioned.
Yep.
Was the prolactemia. So she said that also happens with males. So she said if like a male is saying that there's like white stuff coming out of his nipples, he's not that crazy. It's actually a side effect.
Okay, nope, that's good to know. So my goal tonight is, you know, when we had test 2, I did the top 10.
Yeah.
I'm really trying to get this neuromuscular down to top 10. Because you know, some people said they want questions. It's like, oh my God, personality is such a nightmare. Because most of the questions, you're gonna have several questions on meds, and I tell you, because that's exactly what happens in psych and even NCLEX. But then they want you to know how to respond. And that's what I want to try and get it down to some of the top 10. You know, Yeah, the clusters can be helpful, you know, but if you know paranoid, schizoid, the more your odd, eccentric, suspicious ones are in A, you know, manipulative, splitting behavior is in B, and then the ones, anger, anxiety, fearless, the ones that tend to need you to care for them, that depend on you, is more the C. So I'm gonna say 9 out of 10 times, it tends to be A and B that questions are asked. But I'm gonna see if I can't get that down. That's what I was working on right before coming in here. And that's why I got a lot of notes on this, trying to get it down so easy. Easy that you can take for the NCLEX and easy that you can take for this test. So I'm gonna drive home, give me a couple hours, and I hope by morning I will have a top 10 site for you. But it sounds like you're in really good shape. You blew away, most of you blew away test number 3. I think you're gonna blow away this test. It's just take your time. I'm gonna do another review twice tomorrow if you wanna go through it again.
But they're the same review.
They're the same review, and then, you know, Wednesday I have less available time, but I'm meeting with a few people, because I gotta run out in the middle of the day and come back. So, but, you're gonna do it. I want every single one of you to do this. You've gotta do it, because then we're gonna move on to the 75%, because then you're gonna go on like a treadmill like you've never seen before, because you gotta do that 75%. And then, you know, don't forget, you do have, if you're incomplete, if you don't get the 90% probability of passing the predictor, you get an incomplete. But basically, I'm gonna say 90% of the students in April came to Catherine and my review. I'm going to set that schedule this week. I wanna start it as soon as I can in August, and it'll probably be Wednesdays and Saturdays in August and September. So my goal is for most of you to start taking your NCLEX right in September. You know, go for intense studying.
Girl, that's my goal
Okay,
too.
so obviously, the rest of this week, my focus is on this test. And then I'm focusing on that 75% on.
When you leave here Thursday, your goal is 75%.
Okay, and then the following week, we have the ATI review course.
Yep, and that's just sitting through the class, but in the evenings, because you cannot afford to miss a day with 75%. You know, there's a few students last semester who got a little concerned, like, oh my God, they haven't done anything. And they did come close to not completing it, but we've had every other student complete it. So you really just gotta keep working, every day.
We could show the percentages. Like, I'm not sure.
Oh, if you print it out, it tells you what, like,
Is it, yeah.
Yeah,
like, once you get to a certain point, you're
I
at
think
75%.
like after maternal,
Maternity, I think 75%, and then there's 2 more to get to 100%.
yeah.
yeah.
So every module, like doing the modules, just doing all the quizzes, retaking them and like getting good grades and reviewing, and then this.
Move on, right?
They
Come on,
go.
have, ATI is really strange, you can get to 75%. You know, once you hit 100, believe it or not, it seems like that takes a while, because you hit 100, and now they want you to do 2 tests, and then you gotta study in between, so it's almost like the 100 to the green light seems like that's a little longer. But going to 75, you should not have a problem. We moved the test up for this purpose. But I think if I can get this down for you guys, you get the rest, and you should be able to ace this. And I get to.
No.
Now, you said that the Catherine has to have on Wednesdays